So if you can load my slides, and super excited with the talk I was given. I always get the best talk titles when I come to Houston Shock. So low EF, New York Heart Class 3, and I will tie this into this session about the survivor from cardiogenic shock related to hemodynamic profiling and the use of CPET. Here are my disclosures, which I feel none are relevant to this talk. So twofold goal, I want to provide the basics of hemodynamic and cardiopulmonary exercise testing in patients with symptomatic heart failure with specifically reduced ejection fraction. I hope to define the role and put forth the concept that these are complementary testing. So we have a number of classification models, and certainly New York Heart Class is one of our oldest, and patients with more overt symptoms reflect severity of underlying heart failure and poor prognosis, for example, rest breathlessness. And particularly those with New York Heart Class 3, the title of the talk, typically fall into the stage C category. And he had highlighted stage C different from stage D, which is end stage. And then using the INTERMACS profiles, which was designed to define appropriateness in terms of timing for LVAD in particular, these patients without rest breathlessness, but restlessness with mild exertion, typically fall into INTERMACS 5, 6, and 7. And typically, these patients are in the, regarding SKY staging, are in the, at most, at-risk category. And so how to put all this together is going to be a key. We reserve saying stage D for those whom we feel have a one-year poor survival trajectory, typically in excess of at least 10% mortality at 1 year. The more specific you are with a higher percentage of likelihood of dying, the more concerning it is for that individual patient. So there is some institutional biases on what qualifies as end stage, but this testing can help us in this regard. And so hemodynamic testing, this is a historical stance where it was certainly an appropriate Class 2A consideration for all patients formerly being considered for transplant in LVAD use. And while we had not been recommending Swan-Ganz use for everyone, in those whom you couldn't get a good handle on exam of perfusion and filling, it was a recommendation to use Swan. So this is Yancey and colleagues' publication back in 2013, which had defined the guidelines. Fast forward to the 2022 AHA-ACC heart failure guidelines. Again, in selected patients where it's difficult to ascertain, especially in the context of worsening symptoms, Swan's hemodynamic profiling can be helpful to 2A, but we certainly are not advocating use for all stage C patients in clinic. And so this was shown, Jordan did a nice job of, it's always important to put symptoms in physical exam and try to profile patients as having normal hemodynamics or being just wet with good perfusion or being wet and cold, which is associated with a worrisome prognosis. And so if we can't glean that, and because we know it influences survival. And so here, those that are wet and cold, if you look at their event-free survival, they actually do the worst in terms of how they perform, how they do over the next 1 to 1.5 years. And so we were using Swan-Ganz tailored therapy really to exclude significant pulmonary hypertension for transplant, but also to prognosticate. So it's a prognostication strategy. And this comes from Lynn Warner Stevenson. And when patients had a wedge above 16 that remained there despite leveraging the hemodynamic profile and using IV medicines to try to improve upon that profile, those that stayed decompensated did the worst. That's in contrast to those where they had a high wedge and we were able to get their wedge under 16. They actually fared just as well as patients post-transplant. And so we use their response to the Swan-Ganz in the hospital to help prognosticate. We've taken it a step further, and in the heart failure unit in Ohio, we look at everyone's full hemodynamic profile, including systemic vascular resistance. This is a snapshot of 21 patients where they had a low cardiac index. You can appreciate the value there of 1.67, but in the presence of afterload mismatch, we actually use nipride or high-dose nitroglycerin. We use the Swan in for a day or two. We transitioned then to an oral vasodilatory therapy. We're now using Entresto, and we've been able to see these acute de novo, acute on heart failure complications, even in the presence of low output, to get them on medical therapy, because it's all about recovery. Recovery, recovery, recovery. If you can avoid transplant or LVAD, that's always the best route. And so we use hemodynamic response to guide prognosis. And so take a step back. What is a complete hemodynamic assessment? You want the blood pressure, heart rate, right atrial pressure, RV systolic and diastolic, mean pulmonary pressure, a good wedge, as well as a good output assessment, and you want both peripheral and systemic vascular resistance. And we know from Garen's colleagues' work and others, and those with a more complete assessment, they actually have a more favorable outcome, trying to link the potential benefit of a SWAN in a more advanced heart failure patient population, as exemplified here. So when measuring the wedge, it should be equal to or lower than the diastolic. Nothing bugs me more when I see the pulmonary diastolic lower than the wedge, and I'm trying to make sense of the accuracy. And so you got to look at the tracings. It's all about end expiratory and confirmatory wedge if it's unclear with wedge saturation, in addition to fluoroscopy. And so there are special considerations. I'm not going to go into all the details, but we know we don't use digital means, but when we look at end expiratories averaging multiple cycles, it's the best correlate to LV-EDP. Cardiac output measurements, gold standard is direct FIC using a metabolic cart. This is not as practical and readily used. There is some expense to it. So at our institution, we do both thermodilution and indirect FIC, measuring 2 PA sats, and then we have a recording of the cardiac output and index by both these methodologies. Lower thermodilution cardiac index, there is some data that it appears as a better predictor of mortality compared to indirect FIC. You want to avoid thermodilution in those with intracardiac shunts. And we used to think tricuspid regurg would falsely lower the cardiac output. There is some newer data to say that's perhaps not the case. So get both, I think, would be the most pure way to understand cardiac output. Not going to go into a lot of details with regard to provocative testing, but we try to tease out, high wedge in these HFpEF, focusing this talk on HFrEF. In those with afterload mismatch, we will use nitroprusside to understand cardiac output increment, and while we reduce SVR and blood pressure stability. So I think there is a role for that. Now I'm going to transition to cardiopulmonary exercise testing. Peak VO2 measures the maximum aerobic capacity and is consistently associated with mortality. Peak VO2 is proportional cardiac output. We know cardiac output is the product of heart rate and stroke volume. Here's the actual formula incorporating hemoglobin and AVO2 difference. I think it is important to recognize that modality does matter. Peak VO2 max is higher on treadmill than bicycle. And so the Weber classification really guides us in terms of what is normal. You and I should have a peak VO2 hopefully over 20 versus mild versus moderate versus severe. And we know there's no shortage of literature in that those with a peak VO2 under 14 in the context of HFrEF have the worst prognosis. And so here's a nice study that really looked at peak VO2 compared to wedge, compared to LVEF, compared to cardiac index, and the peak VO2 in particular, based on multivariate analysis, was the better predictor of worse prognosis, as exemplified on the right-hand side of the screen. So we use it to predict one-year survival. We're not hanging our hat on any one parameter in isolation. This comes from the Heart Failure Action trial, 2,100 patients, and as the peak VO2 is lower, and there is an adjustment for gender, and age, and some formulas account for height and weight, but the lower the worse, and when we start to see peak VO2s under 12, we're worried about a mortality in excess of 10% over the ensuing 12 months. We do look at VO2 percent predicted, and it's very helpful in these patients that are overtly symptomatic, but when they do not have reduced aerobic capacity and good pulmonary parameters, perhaps deconditioning. So it does help us tease out that as a concern. The other parameter I think that's very important to understand is ventilatory efficiency. This is minute ventilation relative to gas exchange in terms of the amount of work needed to exchange 1 liter per minute of CO2. One can look at the slope and tease out more efficient versus less efficient, as exemplified on the bottom portion of the screen. And going back to classifications, when we start to see VE, VCO2 slopes in excess of 35, moderate or higher, excess of 36, moderate or higher, we're concerned about prognosis. And a couple of take-home points, it's valid even in a sub-maximal exercise test. It is associated with mortality in an independent manner. It's not dependent on modality, bike or treadmill. And so the basic interpretation, much like hemodynamic profiling, is looking at all these parameters. Was there adequate effort based on the RER, respiratory exchange ratio, and not losing sight of blood pressure, heart rate response, and looking at peak VO2 and the VE, VCO2 slope. So let's take a step back and see what our societies tell us in terms of where these modalities fit. And on your left is the ESC definition of advanced heart failure, and on the right, the ACC-AHA. And you can appreciate some of the overlapping parameters. High-grade symptoms matter, even if it's just New York Heart Class 3, underlying remodeled hearts. But when we start to see by functional capacity, exercise capacity testing, peak VO2s under 14, or a 50% predicted less than that, we become concerned. And similarly, especially in the presence of remodeled ejection fractions. So here's the guideline recommendation for cardiopulmonary exercise testing. It is a class of recommendation number 1. Those that have a peak VO2 over 14 is stage C. Under 12 in the setting of beta blocker, more concerning for appropriateness with transplant listing or LVAD consideration. That certainly needs to be individualized. And there is data when you want to try to tease out. Some patients, especially men, in the absence of their wife will say, I feel great. And you're like, how can you feel great? You look horrible. You don't say it like that, of course. You put them on a cardiopulmonary exercise test and their peak VO2 is under 14, where they're at least New York Heart Class 3. So I'll ascribe, remember that's a subjective assessment from the patient's report, but you can use cardiopulmonary exercise testing to really tease out their New York Heart Class profile objectively. And again, we don't hang our hat on any one thing. Here's a nice report looking at those that had abnormal values as defined in the lower portion of the screen, a VV-CO2 slope over 36, a percent predicted peak less than 50%, poor ejection fraction, and high-grade symptoms. They have the worst prognosis. So in summary, take-home messages, hemodynamic testing remains indicated in selected heart failure patients with high-grade symptoms, certainly those undergoing formal evaluation or where the clinical exam in the presence of persistent symptoms is unclear. CPET, class 1 recommendation to help determine appropriateness and timing for VAD or transplant. Keep in mind the numbers I mentioned related to the CPET, peak VO2, and VEV-CO2, and these tests are complementary in the context of candidacy for end-stage heart failure interventions. Very much giving you that whirlwind tour of hemodynamic and CPET profiling. Look forward to the discussion. Thank you.
Thank you so much for that really quick rapid-fire lecture on hemodynamic and cardiopulmonary stress testing. The question I have for you, which I'm going to take it a little step further, what is your thought process on those patients that are right at that cusp, where they are NYHA class 3 symptoms, they have a VO2 max of about 14.8 to 15, and their index and output isn't that quite low. And what do you think about other device therapies that are coming out and, they're not quite heart transplant or VAD ready?
So I think these tests help us with shared decision making, and part of that process is projecting how patients are going to do with continued standard of care with medicines versus early evaluation for transplant or LVAD, perhaps versus consideration for other FDA-approved devices. And so I very much like exercise capacity assessments. 6-minute walk, which I didn't talk about, when under 300 meters is a poor prognosticator. The CPET under 14, right? Certainly under 12 on beta blockers would be concerning. And we'll do hemodynamic profiling to further corroborate whether that symptom burden is indeed mediated by hemodynamics. Because it's going to help us give the better picture to the patient and their loved one in predicting 1-year survival. Not an easy task, right? To predict 1-year survival, to say, you know what, I think we need to work you up for an LVAD in the outpatient setting, knowing that decision-making is above and beyond survival alone in those ambulatory patients, or early transplant listing. So I think it gives you an objective benchmark. I think it positions you to have that discussion with the family, but I wouldn't just hang my hat on any one parameter. You're going to take into consideration their symptom burden, their degree of their LV remodeling, the presence of any end organ dysfunction, and their exercise capacity assessment and hemodynamic profile to best make a decision on watchful waiting versus doing something else. Related to approved devices, you always pursue chronic resynchronization therapy in selected patients. It will alter the trajectory. Patients with severe MR, with high-grade symptoms, compromised functional capacity, TEER or mitral reduction therapy would be appropriate and indicated. We're not using as much BAT or CCM therapy. It doesn't have the same survival advantage as some of the other platforms, but it is under appropriate consideration in selected patients that are persistently symptomatic. you may not need the profiling as much as it relates to trying to tease out appropriateness for formal evaluation. So certainly a long-winded answer, but you want to individualize it as best you can, and the results can help you do that.
How do you weight the results that you're getting with patients who don't reach anaerobic threshold?
Yeah, so when you have a submaximal test, we advocate looking at the ventilation efficiency, the VE VCO2 slope, because it's still a prognosticator if that RER is still under 1. And so if I see a value over 40 and they're symptomatic, even though they didn't meet threshold or it was submaximal, that still matters. And then again, you want to put it in the clinical context of other findings, their symptom burden, end organ function, degree of remodeling, and hemodynamics. And so if the totality of the findings are pointing to a worser prognosis as one best can estimate over the year, then we'll act accordingly. So the short answer is the VE VCO2 slope.
Does your facility utilize exercise right heart caths at all? This is something that's a little bit new to me.
So exercise right heart cath testing, I think, is more specific to tease out the diagnosis of heart failure with preserved ejection fraction when rest hemodynamics, either measured by echo or in the cath lab, suggests that the filling pressure is normal. And when you exercise them, their wedge and or pulmonary pressures can go up to help clinch the diagnosis of impaired relaxation to guide therapy. And so we'll use it in a HFpEF population where it's not as clear. If I see someone with shortness of breath, edema, and look at their echo and their LA is overtly remodeled and they have a EE prime closer to 20, and I may not need an exercise test to say you have heart failure with preserved EF, especially if biomarkers point to the same diagnostic criteria using HFpEF scores. So we'll use it for selected patients where it's not as clear to ensure we have the right diagnosis. Excellent questions. Very much appreciate the opportunity.